Good afternoon, everyone. On behalf of the American Society for Clinical Pathology and its Virtual Pathology Grand Rounds team, it is my honor to be introducing our speaker today. Before we go on to the introductions, I'd like to just give a housekeeping announcement that credit for claiming CME will be put in the chat. You'll also be receiving an email with that link tomorrow as well. Without further ado, my name is Kamran Mirza, and on behalf of our committee, it is my honor to present to you and introduce Dr. Joe Chaffin. He really needs no introduction. If anyone who has completed pathology residency training that did anything associated with blood bank and transfusion medicine, you obviously know his name. If not his direct name, you obviously know him as blood bank guy. So this is quite a fanboy moment for me to be introducing him. Dr. Chaffin is a transfusion medicine educator in the Department of Pathology and Human Anatomy at the Loma Linda University School of Medicine. He graduated from the Anatomic and Clinical Pathology Residency Program at Walter Reed Army Medical Center and is board certified in Anatomic and Clinical Pathology and Blood Bank Transfusion Medicine as well. Dr. Chaffin has practiced pathology in a wide array of settings, but teaching the essentials of transfusion medicine has always been his professional passion, and we are all witness to this. He helped pioneer online medical education by creating Blood Bank Guy. The website started in 1998 and hosts over 200,000 unique visitors every year. In 2016, he launched the Blood Bank Guy Essentials podcast, which is an award-winning educational interview series for which he acts as both host and executive producer. In 2019, he was honored with the prestigious AABB President's Award for his role as master educator and in furthering online teaching in the fields of blood banking and transfusion medicine. For the past quarter century, Dr. Chaffin's work has impacted thousands of students and medical professionals worldwide, and he continues to guide learners towards the mastery of transfusion medicine. Today, the title of his session is Blood Wars, Talking to Your Doctors About Transfusion. Please join me in welcoming Blood Bank Guy, Dr. Joe Chaffin.
Thank you so much, Cameron. It is a true honor to be here with you guys today to have a chance to talk about one of the things that I'm just incredibly passionate about, and that's the basics, the essentials of transfusion medicine, and especially talking to people that don't necessarily do transfusion medicine every day. And that's kind of what I want to make clear about this talk from the very beginning. I realize that there's going to be some of you on here who have more or less experience in transfusion medicine. I was just scrolling through the list of attendees and I saw someone on there, Dr. McCullough, I'm speaking to you, who knows 20,000 more times more about transfusion medicine than I ever will. So Jeff, I thank you for being here. But for all those of you that are here that are just hoping to get just a basic look at some important things, especially in the middle of where we are right now, when we have so much going on in terms of blood shortages and controversies about transfusions and things like that, I want to give you the basics. I want to give you some tools to use as we go forward to try and make sure that we're all talking the same language, that we're all on the same page as we move forward to try and get to a better place. So Cameron, thank you so much for that introduction. Is very, very kind of you. I have to say that when sorry, I'm just having trouble making my slides move. Give me just a sec. There we go. That when I hear kind words like that, especially about the AABB President's Award, which is just an amazing honor. Anytime I have a tendency to, get big-headed or anything, things have a tendency to bring me back down to earth. And this is just an example. So a couple of days ago, just last Friday, I was donating blood and decided to tweet something out about it and to just show, the world that it's a good idea to donate blood. And you can see the tweet that I sent there. And I got a response shortly from AABB. This is the same AABB that gave me the prestigious presidential award a couple of years ago, which was great and very nice. And so they responded to me, and I have to tell you, it really made me laugh. So you can see what they said there. Of course, I think you see the typo, which just cracks me up. Again, if I ever thought of getting a big head, that would bring me back down to earth really quickly. So I hope that those of you that are here today that you don't feel that way, chagrined at the end of this talk. But I want to walk you through some things today. First, we'll talk a little bit about the COVID-19 related blood. I want to say shortage, but it really is a crisis and it's been going on for a while. I want to talk to you a little bit about that and give you some tips on how you can manage things in your hospital in those situations. But I'm going to spend a lot of time talking about patient blood management and how it fits in with how we practice transfusion medicine today, and in the context of a blood crisis and how we fit all that in together. So we'll talk a little bit about the blood products as well, certainly just the main blood products. We're not going to go into great detail on every single blood product, and mostly focus in on what the evidence says now for how these blood products should be used. So I don't know about you, but if I never hear the word that you see on your screen again, unprecedented, I think I'll be a happy guy. I've heard that said so many times, but I have to tell you, in terms of the blood shortage / crisis that we're going through right now, in my experience, it really is unprecedented. I've been doing blood banking full time for 25 years or so, and I have never seen the blood inventory across the country be as bad as it is for as long a period as it's been. You can see, you've seen some of the headlines from back in just January. Red Cross declares first ever blood crisis amid the Omicron surge. California officials ask residents to donate blood amid severe shortage. The New York Blood Center announces a blood emergency as Omicron. Crisis is not enough. Emergency is what we've got as Omicron spreads. And quite frankly, you see those two, the New York and California issues. Well, frankly, if I'm being honest, blood shortages along the coasts, the margins of our country, East and West Coast, have been kind of a thing for a while, right? But the middle of the country hasn't really often struggled that much. Well, recently we're seeing some trouble with that as well, in terms of a place like Wisconsin, for crying out loud, that's in dire need of blood donations. So again, we can say this is unprecedented, but the truth is, if we look at blood collections over the last 10 years or so, we would see that they are nowhere close to where they were 10 years ago. Now, we're lucky because blood usage is way down from 10 years ago as well, quite frankly. And there's some of that probably is a little bit of supply and demand. But the reality is we've been struggling with blood collection for a very, very long time. And it's really just being manifested more significantly in this time of COVID, where we've got so many blood drives being canceled, blood centers not being able to go into high schools, for example, big surges and all kinds of stuff that's put us in situations that are really, really challenging. We could spend a lot of time talking about the whys of that. I'm actually doing an interview in a few days with the president of the AABB, sorry, not the president, with the chief medical officer of the AABB to kind of discuss that. So you can see that in a future podcast episode if you would like. But for now, let's just talk about the fact that those of you that are working in hospitals are finding yourselves doing things and answering questions that you've never done before. For example, you're hearing questions like, hey, why don't we have blood? Hey, why can't I have blood? Hey, when will we get blood? All questions which are great questions, but are not necessarily ones that you, if you're not a transfusion medicine expert, have the most visibility to. Of course, I really like the snarky ones like this. I never had blood problems in my last hospital. What's wrong with this place, right? Can I just give everybody O negative? That's one of my favorite ones. I really like that when a surgeon or an anesthesiologist typically gets the bright idea that, we'll just give everybody O negative. If there's blood shortage, no problem. It'll all be good. Don't get me started. And another favorite is, what? Psst. My patient is really important. So come on, hit me with it. Slip me with that stuff, huh? Well, so if you get questions like this, and again, this talk is primarily focused towards those of you that are not necessarily quote unquote blood bankers. You may find yourself in a position where you don't really know how to answer, and you feel like you're out of your depth. You do surge path most of the time, and transfusion medicine, really? I have to answer a question like that? Obviously, this happens more in hospitals and facilities where there is not a transfusion medicine expert, quote unquote, on site. But here is my most important message to you. and I mean this sincerely, this is really important to understand. The most important message is that your audience, the people that you're talking to about transfusion, and I'm talking about physicians who order and transfuse blood primarily, and nursing staff, certainly with the physicians, what we know from clear data is that the vast majority of them have only had 1, 2, or maybe if they're lucky, 3 hours of transfusion medicine expertise at any point, instruction at any point in their professional lives. The reality, you know more than they do. 100% guarantee that. And here's the truth. You can do this all day. You absolutely can. You are in a position, believe it or not, where you have enough knowledge to help people with these problems. And I'll give you some practical tips in just a second, but let me give you an example of this. Let me just share with you a little bit about how this works for me personally and what I could tell you about this. Well, this guy that you see on the screen, that's my big brother. That's my big brother, Jack Chaffin. He's an amazing pathologist. He lives in Boise and works there. I would say that in virtually all aspects of pathology, he knows more than me. I don't have any problem saying that. He's brilliant, and his expertise is amazing, especially in surgical pathology. Now, I haven't done surgical pathology for about 12 years or so, so I would in no way compare my knowledge to his. However, if somebody came and asked me a question about, hey, could you help explain something on this surgical pathology report, and it was a clinician asking, I could do it. I wouldn't necessarily know all the details, but I know more than that person who's asking me does, and I could probably get you a good answer. Oh, I forgot to show you my next slide. This is just an example of the head start that my big brother had on me in terms of getting that knowledge. Look at that, right? Look at the little dude there. Look at my little jug ears. What's going on? Anyway, but the bottom line, and here's what I want to tell you. Whatever you think in terms of what your knowledge base is in transfusion medicine, you have had more training than the people that you're talking to. And the fact is, you know enough to help them. You really do. So let's talk a little rubber meets the road stuff. Let me give you some practical tips for if you are one of those pathologists who is in a situation where, or a laboratory scientist, where you're in the situation where you're having to talk to people about transfusion in conversations that you've never had before because of this blood crisis. So the first thing that I want to tell you is so important, and it's something that is really missed a lot. Get to know the physician overseeing your blood supplier very well. And here's the thing, I have been in that role. I've spent much of my career, at least parts of my career, in that role as a blood center physician, chief medical officer in a couple of different blood centers. The physicians in those roles are generally really, really happy to help you. And if you develop a relationship with them where you can text them a question, where you can call them with a question, and it's not really all that hard to do. Now, I know that in some blood organizations, they seem huge, but find out who your local physician is, or the physician covering your local area. Get to know them, talk to them, because they can really help you when you feel lost. They absolutely can. And the vast majority of them are more than willing to do that. Second, in terms of your local hospital, involve your administration. Get them involved early and often. This shouldn't be a scenario where you as the pathologist are sitting there as the gatekeeper of a really short blood supply. And that goes along with this next one. Get full involvement of your medical executive team as early as you can. Have those discussions about, this is what we're facing. This is not a time for us in the laboratory. And we tend to do this. Historically, we have tended to do this. Well, the blood's a little short. Let's just manage it as best we can and not let anybody know. Hopefully nobody will notice. This is not a time for that. This is the time to have full open discussions about the struggles that we're facing still, though it's my impression that things are a bit better than they were a month ago, but they're still not great. Have those discussions with the medical executive team, get buy-in, and further build a system, not a series of one-offs. In other words, if you make something where you as a pathologist or you as a CLS has to make every decision, it's usually the pathologist, about every unit that's going out, that's not sustainable long-term. And again, I get it. Most of you that are listening that aren't transfusion medicine docs, you don't have the bandwidth to look at every single transfusion every single day. So build a system where you set up criteria for when you should be called and when you shouldn't be called to answer questions. further, understand that no one, quote unquote, wins every time. And that ranges from you all the way to the clinicians that are ordering transfusions. Nobody's going to get exactly what they want every time. But when you're in a time of crisis and when you're dealing with things in a way that's a team approach, you can generally try your best to do the right thing for the patient. Again, you're not going to win every argument, every discussion. And sometimes you're going to end up giving blood when you feel like you might not want to. But again, that's partly why you want to build in a system and build in involvement from your administrative staff. And then finally, my best advice to you is this: use evidence-based decision-making whenever you can. Take the emotion out of it and try and follow what the data says to this date in terms of how these blood products should be used. And that's what I want to spend the rest of my time with you talking about, is what the evidence shows today and in recent years, certainly, about how best to transfuse people, how people should be transfused as best we know. So that leads us to a quick discussion of evidence-based medicine. This is a phrase that certainly everyone is very well familiar with. It's just the application of the scientific method to medical practice. And you see the steps down there on the bottom right of the screen. Well, basically and we have over the years tried our best to assess the available evidence and try and predict outcomes as best we can. Now, the problem with that is that it's been really, really challenging in transfusion medicine to get to the point where we have that data, where we have those randomized studies. So the concept applies, but we're challenged by data. So, and I'll share more about that with you as we go along. The simple fact is, we used to make cell phone calls this way, and we used to transfuse in certain ways, and both should go away. And I'll share those with you as we talk about the individual blood products and how they should be used. Well, the how they should be used kind of falls into a big category that we like to call patient blood management. And patient blood management is not necessarily a complex concept, but it is a big, broad, overarching concept in terms of how we look at how people are transfused, but not just how they're transfused. It includes, yes, giving transfusions only when necessary, but it looks at the whole patient from the perspective of how can we make sure that this patient is optimized, perhaps so they don't ever come to the point that they need transfusion. So there's a whole bunch of different things that we can do, and we'll talk about some of those in just a sec. But realistically, why do we need blood management? Well, as I said, we have decades of anecdotal practice, decades of people practicing in ways that is not supported really by any science. And realistically, we've been trying to go with, and FDA has been trying to go with this model of blood as a drug for many, many years. But the truth is, if blood were actually a drug, the data that we have had in the past, certainly, and really still a lot of the data that we have today, blood would never be approved as a drug, simply because there's not great evidence for benefit in many cases. And the evidence for lack of harm is not only minimal, there's some evidence for significant potential harm from transfusion. So that's the reality that we've dealt with over the years. And truth be told, the way that transfusion has happened here in the United States, and let me just say for a moment, I recognize that there are people listening from other parts of the world. So forgive me, I'm going to focus mostly on the United States, but I think the principles are going to be pretty similar for you. But in the United States, certainly, as the fear about transfusion being transmitted through HIV that started in the 80s and lasted and certainly until the early 90s for sure, and really to an extent still lasts today. But as it waned, as it decreased, as blood kept getting quote unquote safer and safer, blood use really spiked in the 90s and 2000s, to the point where at some point in my career, I really felt like this is the way blood was being looked at. Let's just grab some and go. It's awesome. Let's do it. So patient blood management aims to take a look at that and to try and put some science behind it, and to try and, again, not just limit transfusions, but optimize patients. So this is just a graphic that just kind of shows some of the really important facts about blood transfusion. And this was made a few years ago, not by me. I believe this came from the Society for the Advancement of Blood Management, but forgive me, I could be wrong about that. It's certainly true that blood transfusion is the most common procedure performed during hospitalizations. That surprises people. and that 11% of all hospital stays include a transfusion. So transfusion is a big deal. Transfusion happens a lot. And realistically, when we look at the costs of transfusion, oh my goodness, when you're looking at millions, over 10 million blood products transfused every year across the United States, the cost of that is well over $3 billion a year to the healthcare system. And further, when in certain studies, I don't want to say that this is true necessarily across the board, but in certain studies, when we looked at red cell transfusions specifically and looked to see whether they were considered appropriate by an expert panel, there were some cases where as many as close to up to 60% of those transfusions probably could have been done without. You might not have needed them. And that's a huge number, and that should startle you. I hope it does. It startles me, frankly, the first time I saw that. But there's more, you guys, there's more. And this is something that you really need to understand. There are very clear signals that are in various stages of quote unquote proof. I will frankly admit that. But there are a large number of signals that suggest that implementing blood management methods and decreasing the amount of transfusions, yes, but more optimizing the patients has some really significant effects on those patients. There is data suggesting, well, obviously the red cell transfusion rate is going to go down when patient blood management occurs, but things like acute renal failure, post-op infections, thrombotic events, and even just mortality, as well as days length of hospital stay, all those things, there are signals that implementing a patient blood management strategy can improve patient outcomes. And that's a big, big, big thing. And it's really important to understand that. The Society for the Advancement of Blood Management, the group that I mentioned before, came out with this graphic a couple of years ago. And SABM is a great organization. My friend, Dr. Carolyn Burns, has worked with them for a very long time. And I think Carolyn's on this call. I'm actually not sure if she is or not. I think she was going to be. Yeah, she is. Hi, Carolyn. Carolyn was kind enough to share the last slide with me and this one as well. So when you look at what we're talking about, realistically, again, we're not just talking about reducing transfusions. We're talking about managing anemia by doing things like checking a pre-op patient for anemia as early as possible. And if they've got anemia, figuring out why and treating it without red cells. We're talking about intraoperatively and postoperatively, and when in the hospital, minimizing blood draws, doing intra-op salvage, considering methods like hemodilution that can again help reduce the amount of blood that a patient gets. Of course, optimizing coagulation. For examples, making sure that you stopped anticoagulant therapy as early as possible before patient surgery. That's a big thing. Consider implementing things like viscoelastic testing, TEG, ROTEM, things like that. Again, all these are not just like instant snap your fingers and make them happen, but these are things that patient blood management programs can really help with and benefit a hospital, and more importantly, benefit patients. And finally, using those evidence-based thresholds that we're going to talk about in the next half hour or so, super, super important to try and transfuse patients as appropriately as possible. So I hope what I've shared with you so far suggests to you that there are some benefits to doing patient blood management, to trying to optimize patients from the transfusion perspective, resulting in more appropriate transfusion and further, more importantly, better patient care. So I think that the drivers of patient blood management, when we look at them, yeah, better outcomes. That's absolutely right and absolutely awesome. I think fewer complications, again, absolutely right and absolutely awesome. But I'm not naive, and I know you're not either. And the reality is that I don't think we would be having this much of a conversation about patient blood management if there wasn't something else involved. What could that be? What could that be? And the reason I know this is that over the years, throughout my career, as I mentioned, I've been doing this for a long time. As we look at how clinicians, physicians ordering transfusions and pathologists, your friendly pathologists, right? And everybody's friendly on this slide. That's okay. Maybe that's a little naive. Those discussions have been going on forever. I've been having those conversations with clinicians about some of the stuff we talked about and some of the stuff we will talk about in a few minutes about when transfusions should happen. I've been having them for my whole career. And for the most part, they've been friendly. They haven't always been all that productive. People, as we'll talk about, people have a tendency to practice in ways that aren't necessarily supported by data. But recently, there has been another attendee in these discussions. And you can take a look at this picture. Well, in fact, you can actually take a look at this guy and look at his perfectly coiffed hair. And I think you can guess who this group is. Yes, my friends, this is the hospital administrators. Ta-da, this is them. Realistically, as more and more reports from different hospital systems and larger hospitals have come out suggesting large money savings from implementing patient blood management methods, I believe, metaphorically, there are some, at least hospital administrators, that might be saying something along the lines of, so we do this blood management thing and we could save $1 million. I think that is absolutely happening, and it's changed things. So here's what I want to say. And I have said this face to face to hospital administrators. The last thing I want to have happen is have a hospital administrator be interested in whether or not a surgeon is transfusing someone with a hemoglobin of 7 or 8. That is not something that I really want them to be involved in. And unfortunately, that does happen. I've seen that on all too many occasions. I've seen scenarios where administrators start talking to me about, hey, I looked at this data and such surgeon or such physician is transfusing regularly at hemoglobins greater than 7 grams per deciliter. What are we going to do about this? So again, I'm not naive. I understand that there is financial pressure on hospitals. I get that. But when you build your patient blood management system, I strongly advise you to try and keep those administrators out of those decisions. I believe that those decisions and discussions should still happen between pathologists and those who are ordering transfusions. I absolutely believe that. There's one thing I want to say before I move on into the individual blood products, and that's I've talked about some of the other things that we have data on that are suggestive of potential harm from transfusion. The thing that we've talked about for decades in terms of potential harm from transfusion, and I mentioned it earlier when I talked about HIV, is transfusion transmitted infections. And so when you look at the risks, and again, you'll see variations on this in different publications, but I think that it's pretty safe to say that certainly just for example, with HIV, we haven't had, to my knowledge, a reported case of HIV being transmitted through transfusion since 2008. Before that, it was 2002, and then before that, we're back into the 90s. So in the last over 20 years, again, to my knowledge, we've only had 2 reported cases of transfusion-transmitted HIV, and that's with millions, well over 10 million transfusions of blood products happening every year. So blood, it is absolutely true, has never been safer from the perspective of someone getting something bad from a transfusion. You notice on the bottom of that slide there, it talks about platelets being the most risky, basically, in terms of getting back a bacterial infection from platelets. That's absolutely true, but we've taken some steps recently to try and ameliorate that, which is a topic for another day. But I wanted to show you this next slide because I think it's super important. It's a slide done by the folks up in Canada, and it's really terrific. I love this slide because if you look over here at the bottom right, you see that the risk of HIV, Hep B, Hep C, et cetera, it's tiny, tiny. But when most clinicians think about risks from transfusion, that's where they're focused. But if you look at this other stuff, which at least all the way up to here includes things that kill people, like transfusion-related acute lung injury, like transfusion-associated circulatory overload, like ABO incompatibility leading to a hemolytic transfusion reaction, all those things happen way more often, and they generally are not thought of. Realistically, if you look in the United States, I just saw some data from 2019 from the FDA, I believe it was, if you add up transfusion-associated circulatory overload and transfusion-related acute lung injury deaths in the United States in 2019, it added up to 24 deaths. Now, if you change that around and said, hey, 24 people died from HIV as a result of transfusion in 2019, how crazy would that be in terms of the publicity that would get? It would be a massive story, but the reality is stuff like that is happening all the time, and it's an inherent and important risk of transfusion that tends to get not just underestimated, but in many cases ignored. Okay, soapbox over. let's go on and talk a little bit about indications for the individual components. I want to spend the last half hour that we have together kind of going through red cells, platelets, and plasma, just giving you some very high-level basics about the product itself, but more importantly, spending time talking about what data do we have to suggest how these products can best be used. So let's talk first about red blood cells. So here's a unit of red blood cells. They're typically all leukocyte reduced. You don't have to order those leukocyte reduced. We get rid of the white cells early for a variety of reasons, including HLA immunization and CMV and febrile transfusion reactions. At any rate, red cells get stored for 42 days in blood bank refrigerators. And again, we can do a lot of different things to them. We always do leukocyte reduce them, but we can also irradiate them to prevent graft versus host disease, transfusion-associated version. We can wash them in patients that have severe allergic reactions, for example. And occasionally they can be frozen for really rare units that are necessary for patients that are difficult to transfuse. All that stuff can absolutely happen. So why do we use red cells, though? This is the important question. Why do we use them? Well, the real reason, the big reason, the main reason to use red cells is when someone can't deliver enough oxygen to their tissues as a result of the fact that they don't have enough red cells. That usually happens in scenarios where you're losing red cells, like hemorrhage, where you're breaking apart, like hemolysis, and where you're not making enough, as in marrow failure. There's certainly other scenarios where it gets used, just to name a few, to replace problem red cells in sickle cell disease, and even in thalassemias as well, and in neonates with hemolytic disease of the fetus and newborn. All those are reasons to potentially use red cells, and realistically, that seems pretty simple. Doesn't seem terribly challenging, right? Well, not so much. Because what we have seen is that there are very, very, very wide variations in practice. And it's just completely coincidental that I have a cowboy on the screen here when I'm mentioning cardiac and orthopedic surgeons. Just I don't know how it got there, total coincidence. The reality is, again, when you look at the data and when you look at how red cells get used, what you see is, even to this day, and there's a little bit less variation than there used to be, but you still see variations that are super wide, where matched patients that are matched across different hospital systems and across different physicians with similar stages of disease and similar surgeries, there are enormous variations in how much blood and specifically how many red cells get used in those patients. We certainly also know, and we've discussed this already, that the risks are greater than expected. And we also know that historically, we have always talked about using 2 units of red cells as a quote unquote standard dose. And we're changing that advice. We'll talk about that more in just a few minutes. So let's talk a little bit about red cells, and let's talk a little bit let's go to that risk benefit thing, because I think this is really important for us to understand. And I've alluded to some of this before. When we look at red cells, on the one side, we've got things like transfusion reactions, increased post-op infections, acute renal failure, increased length of stay, increased risk of thrombosis. Again, there are varying degrees of certainty about some of this data. I'm not going to sit here and tell you that it is all certain, but I will tell you that there are significant signals suggesting that these are some potential outcomes. And in fact, if you look at data, and this was shared with me by Dr. Burns as well, there is a lot of data suggesting some of these things. And it's important to understand. Whereas on the other hand, on the other side, we've got the fact that red cells unquestionably in certain situations save lives. So how do you balance this? How do you figure this out? Again, it is my belief that every single red cell transfusion should be a very specific weighing of the risks on one side and the potential benefits on the other side. The problem, you guys, is that when we look at this, as I said before, we have a tendency to underestimate these and overestimate these. In other words, what the data suggests when people have reviewed transfusions is that the benefits in many cases do not outweigh the risks. Now, I want to be clear with this. Does this mean that Joe is saying that the only person who should ever get a red cell transfusion is someone who is absolutely going to die in the next 5 minutes without it? Well, no, I don't think that's either plausible or realistic, but I do think that the borderline, maybe I'll give them a red cell transfusions should absolutely not happen. And further, I think that in this time of blood crisis that we're in, when we have scenarios where we just don't have enough red cells to go around, where your blood supplier is telling you, this is all I can get you, and you're not getting a doggone other unit until tomorrow. Those are the situations where those borderline transfusions absolutely should go away. Now, if you ask someone like my friend, Dr. Burns, that I have mentioned a couple of times, she would tell you that that should be the case all the time. And I'm not really disagreeing with that, but that's not always reality. We would like for it to be that way. We would like for the only people to get red cell transfusions to be those who really, really need them. But we know that borderline transfusions happen, and we know that they're not all possible to prevent. But again, if you've got 2 units of red cells on your shelf, and one is for someone who's desperately in need, and the other one is like, you can probably wait, I know which direction I would go, and I think you do too. But you have to be aware of those discussions and be prepared to have those discussions with clinicians to help them understand. Okay, so let's dig a little deeper into this, into the how you decide thing. Well, we would all really like for there to be a very simple measure of when we should transfuse and when we shouldn't transfuse. Quite frankly, it's like me, if my car breaks down, I am no mechanic whatsoever. I would like, when I open the trunk and stare into it like this guy is doing, I would like for there to be a flashing sign that says, right here, here's the problem. That would be great. I would love that if that happened. Whoops, sorry about that. I would love if that happened. I would love to be able to have a marker to show me exactly where the problem is. Simply put, red cell transfusion is a complicated thing, and understanding when a patient needs increased oxygen carrying capacity can be really difficult. There's a lot that we could go into about that. Oh man, I'm so sorry. I don't know why that keeps happening. My apologies. In days gone by, certainly when I was a medical student and when I did my one clinical internship year, the advice was transfuse a patient when their hemoglobin gets below 10 grams per deciliter. I would ask my attendings why, and they would say, well, just because that's what we do. That's what you got to do. It's got to be above 10 grams per deciliter or above 30% hematocrit. And that was passed down for decades. I'm sure most of you that have been around for a while are very familiar with that number because it was very, very commonly stated. Not so much anymore. Nowadays, we've got an overwhelming amount of data. This is one of the things that we do have a lot of data on. In fact, as of 2018, there were over 37 randomized trials with almost 20,000 recipients where we had looked at when red cell transfusion should be given. And that data was summarized in a clinical practice guideline that came out in JAMA in 2016 from the AABB. And there are several recommendations that I wanted to share with you because I really think that these are important, and these are things that you should have in your arsenal as you're having discussions with clinicians. First is that a restrictive transfusion strategy, in other words, transfusing at 7 grams per deciliter in adult hospitalized stable patients, is completely reasonable. Using 7 as a threshold, while it's not perfect, and I would love to have more advanced data to make that transfusion decision, if you got to make a decision based on a hemoglobin threshold, and frankly, that's the position we often find ourselves in, it is 100% reasonable to use that 7 grams per deciliter. If a patient has a cardiac disease history or is undergoing cardiac or orthopedic surgery, 8 is considered reasonable. And then there's other scenarios where things are not as clear. I want to show you a couple of the studies that helped us form this opinion. And the first one is one that I believe every pathologist should be familiar with. It's the TRIC study. It was a critical care study that was published in 1999, all the way back in 99 in the New England Journal of Medicine. It was done in Canada, specifically in ICU patients, where they randomized those patients into getting transfusion at a threshold of 10 grams per deciliter, or 100 grams per liter, if you will, because it was in Canada, I'll say it that way, or restrictive strategy, transfusing at a hemoglobin of 7 grams per deciliter, or 70 grams per liter, as they say in Canada and the UK. And the results were startling, frankly. Not only did it show that those who got the restrictive transfusion strategy did just as well, there was actually some signal that they might even do a little bit better, and with a possible exception of cardiac surgery patients, or acute cardiac patients, I should say. And here's what I wanted to show you about that. And that's this data right here. Again, these are how the patients were randomized. This was the restrictive arm where patients only got transfusion at 7. This was the liberal arm where patients got transfused up to 10. The in-hospital mortality was less in the restrictive side, and the primary outcome for 30-day mortality was also less. Again, there's been a lot of discussion about this study over the years. I don't want to make any grand pronouncements about this because, again, there's been some criticism of the study, quite frankly. But I think that the data that has supported this finding since has suggested that 7 is absolutely a reasonable threshold in a patient who's in the hospital, not bleeding, and otherwise clinically stable. What about orthopedic surgery patients? That's something that's been discussed a lot. The FOCUS study was published in 2011, and it looked at 2,000 post-op hip fracture patients, all who had coronary artery disease. And again, used that liberal and restrictive strategy, although they used 8 for the restrictive strategy for the hemoglobin cutoff. And they showed not only were there way fewer red cells used in that restrictive group, but that their primary outcomes in that study, which was death and the rate at which patients were walking after their surgery, was completely equal 60 days later. When we look at cardiac disease, that's where the data gets a little bit murkier. There have been some more recent studies that have again kind of supported using the more restrictive strategy, but the data is certainly clear in cardiac surgery that restrictive strategies are equal to liberal strategies, and transfusing someone using a threshold of 8 is reasonable. It's not clear though when someone comes in an acute MI or unstable angina, and people vary in terms of how they practice in terms of what their threshold is in those patients. And again, in chronic cardiac disease, most studies suggest that a threshold of 8 is reasonable to use. Again, this is just a snapshot, a high-level overview, but I want you to be aware that when you have these discussions with your clinicians, you have data to support you in terms of talking about that 7 or 8 gram per deciliter threshold. Then there's the one that annoys the clinicians. Let's just be honest, it annoys them, because when I was first a transfusion medicine doc, in our meetings where we would go over transfusion practice in a hospital, we would send little nastygram letters to clinicians who transfused 1 unit of red cells. We would say, what is wrong with you? There's no reason to ever transfuse less than 2 units. So I really can't blame them for nowadays when they're hearing the exact opposite, when they're hearing, how dare you transfuse 2 units of red cells? You should transfuse 1 and make sure it does what you want it to do. And if it does, then you're done. Terrible clinician. Obviously, we don't say things that way. Well, but that's the honest truth, is that nowadays what we've realized is that there's absolutely no reason to give a patient more blood than is necessary. And in the vast majority of situations, now granted, this doesn't apply when someone is having a massive hemorrhage on the table or things like that. But in the vast majority of situations, you usually can afford to give a patient 1 unit of red cells, check the hemoglobin, check clinically to see if you've achieved what you were going for, and then stop if you're ready to stop. Now, the objection that I get a lot about that is, well, I don't have time to do that. I just need to go. I just need to give the patient's transfusion and go. And what I always point to is a study that was published way back in 1994. And I have kind of a personal connection to this study, I should say. Not that I was involved in it, I wasn't, but I was at Walter Reed when the doctors who did this study published it, and know some of them, not all of them. But this study shows, and you can see the conclusion, that realistically you can check the post-transfusion hemoglobin within about 15 minutes of I'm about to sneeze, hang on a second. There we go. You can check the post-transfusion hemoglobin within 15 minutes of the transfusion concluding, and you have a great idea of whether or not it's worked. You can see pretty much the full effect. So they don't have to wait hours to do this. They don't even have to wait an hour to do this. Checking the post-transfusion hemoglobin quickly is not just reasonable, it works. And it's a great thing that can help you sell that, you don't need to necessarily give 2 automatically. Let's give the 1 and see how well it works to get you where you want to go. There's a lot more we could talk about with red cells, but we need to move on and talk about platelets next. So let's do that. Again, high-level overview, 2 different ways to get platelets. The vast majority in the United States come from an apheresis collection. In a few places nowadays, you'll see whole blood platelets where we take whole blood, spin it down, separate out the platelets, and we give a pooled product. It's typically just used in trauma services nowadays, whole blood platelets. The vast majority of platelets are given via the apheresis process. And just in case, for those of you that have been around for a while, if you don't remember this, platelets, in whatever way they're supplied, are stored for up to between 5 and 7 days. The 7 days is fairly recent at 20 to 24 Celsius. There's just real quick, the 7 days comes from an enhanced culture process that blood centers had to put in place starting in October of last year that allows us to keep the product a little longer. Again, a topic for another day, but between 5 and 7 days. And some of these products are also pathogen reduced nowadays, where they're treated to eliminate functionally the growth of any organism, virtually any organism in the blood, in the platelet product. At any rate, whole blood platelets, it typically takes about 6 of these, typically 4 to 6 of them, to equal 1 unit of apheresis platelets. The great thing about apheresis platelets is that from one donor, we can generally collect at least 2 doses of platelets, sometimes 3, and on rare occasions, 4 units of platelets from one donor. So again, for those of you that have been around for a while, if you ever hear someone saying a quote unquote 6-pack, that terminology is outdated. That may be what some of you want right now, but that is outdated terminology. There is no need to say that anymore. We talk about platelets in terms of doses, 1, 2, 3 doses of platelets, not 6-packs anymore. All right, so let's talk about what platelets do. I think you guys know this pretty well. You don't need me to tell you that platelets are designed to go to places where the vascular integrity is compromised and binds to those raw surfaces, those collagen surfaces underneath the endothelium, stick to the raw surfaces and stick to each other in order to form a primary plug to stop you from bleeding. Again, you're all aware that the normal platelet count typically runs between 150 and 400,000, and the consequences of deficiency are things that we're all pretty familiar with. Mucocutaneous bleeding, nosebleeds especially, petechiae on the skin, gastrointestinal hemorrhage is a big potential problem. But the thing that everybody worries about with low platelets is what you see on the screen there, and that's the catastrophic intracranial central nervous system hemorrhage. So over the years, what we've realized is that a lot of platelets get used in an effort to try and prevent that catastrophic CNS hemorrhage. And that has led to some controversy in how platelets have been transfused. So one of the things that I love this little thing that from Uncle Albert. Most of the time I'm quoted on the internet. I totally never said that. And my guess is if we could talk to Dr. Gatos, who published a study way back in 1962 in the New England Journal, he would probably say something similar. In that study that he published, and you see the reference down at the bottom, the quantitative relation between platelet count and hemorrhage in patients with acute leukemia, the data that was analyzed suggested, and they made this clear, that no threshold was really predictive of when a patient was going to bleed. But there was some signal in the data that there was some increased bleeding at platelet counts of less than 20,000. Now, back then, we didn't have any idea about how aspirin affected platelets, so no idea whether some of the patients in the study were on aspirin or weren't on aspirin, and so there's a lot of confounding factors. But as a result of just that little signal, the 20,000 trigger was taught for decades. And again, when I started as a pathology resident, when I started as a medical student, that's what I was taught. Below 20,000, a patient has a super high risk of bleeding. As it turns out, that's not true at all. And I'll show you the data on that here in just a second. Further questions about platelet transfusion include the prophylactic versus the therapeutic debate, and that's been answered in HemOnc that it's reasonable to use a prophylactic threshold. More on that in a second as well. And it's also been shown that when patients have some things going on, like fever, sepsis, big spleens, thrombocytopathy, where their counts don't really matter because their platelets aren't working, or if they're already bleeding or have a coagulopathy, that may impact how you transfuse platelets. So here's what we have for now, and I'm starting to run a little short on time, so I'm going to blitz through this pretty quickly. From the AABB, a clinical practice guideline that was published in 2015 suggested these parameters. For the purely prophylactic platelet transfusion, 10,000 is a reasonable threshold. Truth be told, we probably could go lower than that. There's great data out there suggesting that patients don't really start having a whole lot of spontaneous bleeding until they get below 5,000, but 10,000 is a reasonable prophylactic threshold, and it's used very widely. If you're putting in a central venous catheter, 20,000 is reasonable. Doing an LP, 50,000 is reasonable. Major surgery or already bleeding, 50,000, a reasonable threshold. And it also suggested that you shouldn't use platelets prophylactically for cardiopulmonary bypass. And that in and of itself is a topic for another day. But as you can imagine, there's some controversies to this. And I mention this as quickly as I can, simply because I know you guys deal with this, as do I. My favorite one is where you get the call when someone wants to transfuse a patient platelets because they're going to a surgery or because they're going to have a lumbar puncture. And they say the platelet count's 49,000. I've got to get it over 50. My general answer to that is, well, let me take the sample and rerun it, because with margin of error, maybe this time it will be over 50. We all know that 49K is the same as 50K, but unfortunately, in many cases, folks come to us with the publications that they have from, guidelines, national guidelines from various places, like from the Society, the Interventional Radiologists group. And they give these hard and fast thresholds, and they say, if I'm not over this threshold and something goes bad, I'm going to be in trouble. Well, again, in those scenarios, I try to reason with them as best they can and help them as best I can and help them understand that 49,000 is 50,000. But if I can't win that argument, the one thing I will say is, if you're going to do this, I want you to transfuse this product as this patient is being wheeled into whatever procedure they're doing. Don't wait. Don't check another count. Transfuse it and go. At least that way, I might be able to save them chasing their tail over and over and over. Again, a lot to say there. My least favorite discussion is about transfusing platelets to patients who are undergoing liver biopsies or endoscopies or regional anesthesias. Sometimes people try to blow past that 50,000 count, and they say, I've had patients bleed, and by gosh, I need to have it at 100K. And those are scenarios where I will dig my heels in, quite frankly. And really, the data that we have, and I wish there were more of it, does suggest that the count is really not predictive of bleeding. What I usually don't tell them is that the skill of the operator is more predictive of whether or not the patient's going to bleed, but they don't really like that when I say it, so I try not to. It's also true that patients who have intracranial bleeds, that there is some signal that transfusing them platelets, if they're on an antiplatelet medication, may actually make them worse. And certainly in cranial surgery and pulmonary or eye hemorrhage, for places where you can't put pressure on things, there's no official recommendation, but most people will use 100,000 as a threshold. All right, so let's take a quick look at plasma transfusions and finish off our time together. And so, realistically, plasma has grown enormously in the amount that's been given, and it has slowed down in recent years, but certainly for the 20 years between 1990 and 2010, the use of plasma just shot up almost exponentially. One little thing that you should be aware of, it's just a trivia thing. Most of what you look at in your blood bank as FFP is probably a product which takes a little bit longer to freeze, which is called plasma frozen within 24 hours. FFP is frozen within 8 hours, and that can be logistically difficult for blood centers to get meet that 8 hour window. So in many cases, if you look at your plasma, it's probably PF24 in many cases. That's okay. They can be used pretty much interchangeably. But how does this come about? How does the use of plasma come about? It most often happens as a result of a clinician looking at some labs and saying, hey, the coags are out. I need plasma. But more importantly, they typically will say something more like, what they mean is the INR is out and I need plasma. But what does that mean? What does that actually mean? Well, this slide is something that's so massively important that I wanted to make sure I got to it today. And credit where credit's due. I got this from the amazing Dr. Jeannie Callum in Toronto, and it's just a wonderful slide. I love this slide. So let's take a look at this and let me explain it to you, because it's if you went to the Bahamas for a while and you took a little nap, come back to me and just focus on this slide. And there's some really great information here. So let's take a look at this. If we look on the y-axis here, you see coag factor levels ranging all the way up to 100% down to 0. And you see how that corresponds to the INR. Well, if you notice, this dashed line here is actually, it represents the zone of normal hemostasis. In other words, if you have more than 30% of your coag factors across the board, you are going to be able to clot. So what that means, that also means though, that at 30% factor levels, you're not necessarily going to have a normal INR. We can talk another day about how INR wasn't really meant to be used for this, but that is a topic for another day. But you look and you see that the place where the curve for the INR crosses that 30% threshold is at about 1.7. So I think we could reasonably say that in most patients with INRs of 1.7 or below, they're probably okay in terms of coagulation. More on that in just a sec. Now, when we look at this curve a little closer, we could see that the zone of anticoagulation for people that are on warfarin, for example, is between 2 and 3, right? So in case, I always really enjoy the clinician who argues that they have to transfuse someone plasma with an INR of say 1.5 when because they're saying, well, this patient might bleed, but they have a patient who's on warfarin and they have that same INR 1.5, and they're like, oh, this patient can't clot, and they give them, or this patient is going to clot too much, and they give them more warfarin. It just doesn't make sense. So realistically, my perspective, 1.7 or below, the answer to the can I have plasma question is probably, you probably don't need it. But let's take this further. There's more to this, and this is also really important to understand. When we look at someone, let's just say for example, we had someone with an INR of 3.0, and we wanted to knock them down to that 1.7 range or so. If we were going to do that, what is really, really not understood well among clinicians is that it requires typically about 15 mils per kilogram of FFP, and that would typically be in the range of 4 units of plasma. So what I say in scenarios like that is, okay, that little 2-unit order of plasma that you've given is probably not enough. You probably need more, which they're not used to hearing from a transfusion medicine doc, but that's true. Now, further, if you wanted to take that 3.0 and knock it all the way down to near 1, now, again, you probably don't have to in most cases, but if you were going to do that, we're talking a whole boatload of FFP, and that should lead to the discussion of why on earth would you even want to do that? So here's the important part, you guys. Again, I love that slide, and I love the principles that it gives us. If you have someone with, say, a plasma volume of 3 liters and they have an INR of 1.7, and you're trying to throw in a couple units of FFP, and here's another little secret. If I took those units of FFP and ran them on our coag analyzer, I would see that the INR in those units of FFP is going to vary between 1.1 all the way up to 1.4, 1.5. You tell me how that's going to make a significant difference in that massive plasma volume. In fact, it's not. The way I look at it, it's like a cold bathtub, an ice water bathtub, and you take a glass of warm water and try and put it in and try and change the temperature of that tub. It simply does not work. So a lot of plasma transfusions, in my opinion, are futile. So what does work? Well, there are a few things that we've seen over the years that have been suggested as potential indications for plasma. But again, there is hardly any systematically derived data. Certainly, we can say that bleeding or operative patients with coagulopathy from multiple factor deficiencies could and should get plasma, including patients with hepatic failure, with a caveat that I'll get to in just a sec, and bleeding patients who need urgent reversal of warfarin. That's also a big potential deal, though realistically, it's likely that using something like 4-factor prothrombin complex concentrate might be a better choice. So let's talk about hepatic failure real quick, and that'll be the last thing we discuss, or pretty much the last thing. So here's what's important to understand about patients with liver failure. We think about patients with liver failure as being really having significant coagulopathy. And it's true that when you look at them, you're going to see that the coag factors, as well as their platelet count and their platelet function, is going to be decreased. No question about that. So if that was the case, if that was all there was, you would think that the scale would definitely shift towards bleeding. But what is not as well appreciated is the fact that the anti-coag factors like protein C, protein S, and antithrombin will also go down. And in addition, some of the coag factors, 1 or 2 of them, are going to go up significantly, like factor 8 and von Willebrand's factor. So what you end up with is a scenario where this coagulation system is fairly well balanced. And so throwing a bunch of plasma on someone with liver failure who already has what looks like a coagulopathy, because you're just looking at the PT, INR, and PTT, usually is a mistake, because you can tip this balance and you can actually put them in a scenario where they're going to clot too much. And that is obviously not what you want. All right, so there are other potential indications for plasma transfusion, and you see them listed there. I'm not going to take the time to go into them. I would mention that that there are some super important contraindications to plasma transfusion, such as volume expansion and heparin reversal and voodoo stuff like nutrition or wound healing that you really, really don't want to do. And those are scenarios where you should make the argument and should have the discussion with your patients, with your clinicians about how to avoid plasma transfusions in those scenarios. All right, you guys. So I realize it's 10:59, so I am going to stop now. I want you to understand, those of you that feel like you're out there on your own, again, talk with your local blood doc, check out some of the resources that I've made available at the Blood Bank Guy website, as well as the Blood Bank Guy Essentials podcast. I really focus on trying to get education out to folks like you, folks that are trying to do the best they can, that aren't necessarily transfusion medicine experts. So I want to thank the ASCP for asking me to do this. Thank Sarah Wabker and Cameron Mirza for asking me to do this as well. It's been such an honor to hang with you. Thank you guys so much for listening and paying attention.
Thank you all for joining us. Thank you, Dr. Chapin. That was really a great overview and very practical. Some folks have commented specifically on, thank you for bulking up their arsenal of arguments. So I think you did a really nice job including, data, but also talking about how data is not perfect and thinking about context and where those studies were done and what time, medicine was in and things like that. That really does kind of help us move away from just these very, threshold-based approaches to patient care. So I do have a few questions that came in. If there are any additional questions, it's easiest for me to keep up with them in the Q&A portion, but some that I pulled out of the comments. Early on, someone asked about your data that most treating clinicians have less than or approximately 2 hours of blood bank education, so that if you're a pathologist, you de facto know more than them. So this person is asking, are medical students getting any lectures basically in blood banking, sort of more focused on the fact that we are having these unprecedented crises with blood? Is there anything you know of, any moves to make that a bigger part of the education?
Well, I saw that question as well, Sarah, and I'm not sure if the person was asking whether they're getting more now or less now, and both are great questions. I'm not sure the answer to that, to tell you the truth. I can say all I know is anecdotal, and I can say at the place where I work now at Loma Linda University, we are trying to enhance that even remotely, but it's hard for me to say how that's going across the country. I certainly hope that it's being taught more. I would love to see scenarios. I mean, medical schools are implementing things like, virtual case learning, where they're seeing virtual patients and doing things like that. I know that there are places I know that just my friend Justin Kreuter at Mayo is implementing and already has implemented some really good case-based learning with actual virtual patients at Mayo that I know he has said is super, super helpful. I would love to see that be more of a thing. I fear, like Maureen said in that question, that we, during the pandemic, when there's fewer face-to-face lectures, we may be seeing less of it, but I don't have any data on that.
Sure. So another great question from Sarah Johnson. Some of our clinical teams have discovered the magic of directed donor units, particularly platelets, and feel they can get around transfusion thresholds because they have directed units with that patient's name on them available. How would you suggest handling these cases? And note that the friends and families get upset if they learn you withheld a unit that they donated, even if it was not indicated.
Well, that's a great question. I have seen that myself before. When I was chief medical officer at Lifestream Blood Bank here in Southern California, we started to see that. where as a response to the blood shortage, people were requesting directed units. The way I dealt with it at Lifestream was, and this wasn't universally popular, I'll just tell you that right now, is that the way I did it was I made sure that the consent and the information that the people got when they came in to donate directed blood, and because these need to be ordered by physicians, what the physicians were seeing made it very clear that these products, these products, if we were going to collect them, which frankly, I discourage directed donations whenever possible. I am not a huge fan by any stretch of the imagination. But these units that are used, if they are sent, if they go to the hospital can determine how to use them. If they're not used for a specific patient, they can be used for anybody else, or if it's not indicated to use them for a specific patient, they could theoretically be used for anyone else. Because as you know, directed donors have to qualify in every way that a regular donor does, and they get tested in the same way as regular donors. The thing I don't like about them is that because of the fact that you're a directed donor and you're donating for someone, say I'm Uncle John and I'm donating for my nephew, little Timmy, and let me go through this questionnaire. Yeah, okay, fine. Oh, prostitutes, really? I have to tell them about prostitutes? There's potential motivation to not be truthful. So that's one of the reasons I don't like them. But I think that hospitals also need to talk to their blood supplier. If they find themselves receiving a bunch of directed units from their blood supplier, I think there needs to be back and forth with that and give and take with that. Again, one of the things I implemented at my blood center when I was working there was when we got a directed request, before we even thought about fulfilling it, we would send it to the hospital for the transfusion physician at the hospital to have a discussion about it, to talk with a clinician about it, and to see what the indication was, to try and get around this whole, we're going to have a whole bunch of people donating just so that we can, quote unquote, have some blood in this time of blood shortage. It's a challenge, though. It really is. And Sarah Johnston, thank you for asking the question. I don't have the best answer in the world other than try to communicate as best as you can between blood center and hospital.
Yeah, I think that's a great idea about even putting it in your consent so that it's clear that there are other uses. So we'll do one quick comment to see if you have anything else to say about this. So just again, to make this a little more global, Lydia Mora says we have in Europe prothrombin concentrate complex to reverse anticoagulation effect. And so they don't use FFP at all. So I think thinking about alternatives like that could help us here.
Yeah, well, and I did have that on the slide, Lydia. Thank you for bringing that up. I am a big believer in using prothrombin complex concentrate rather than FFP to reverse the effect in someone who has a sky high INR as a result of warfarin in a bleeding patient. I am a huge fan of that. Our problem in the United States was that up until I forget how many years ago, 6, 7, 8 years ago, we didn't have an approved form in the United States that included enough factor 7 to make a difference. It was really a 3-factor PCC rather than a 4-factor PCC that was approved in Europe and has been approved in Europe for a long time. We have that now, and it's what I always recommend. It's more expensive than FFP, but man, you get way less volume. So I'm in agreement with you, Lydia. I think that is a better choice. And I assume that when you say we don't use FFP, I'm assuming that you're saying you don't use FFP for that indication. And again, I agree with that. I would rather use PCC than use FFP in those scenarios.
All right. Well, I want to thank everybody again for coming out, and particularly there was back and forth in the chat with people answering each other's questions. So appreciate everybody sharing their knowledge on here. And again, thank you, Dr. Chaffin, very much on behalf of all of the Virtual Pathology Grand Rounds Committee. We're really pleased that everyone could join today and spend their time with us. So thank you very much. Thank you to ASCP for hosting. And we look forward to seeing you at the next one, which will be in April. So please stay tuned. Take
Thanks,
care.
guys.
Bye.